I'll kick it off here. This is a question for Dr. Horowitz. And I'm going to editorialize and add some of my own question into this. So the question is, were control patients healthy and or non-endemic also tested for pathogens and immunoglobulins? And I'll extend that to my own question, which is, what's the expectation on a lot of these things that you look at from a general healthy population, if you just sampled, what's the base rate sort of expectation for a lot of these things?
Right, so it's a great question, and obviously we do not have a control group. People who come to see me come because they're sick for a very long period of time. But it's absolutely true, and this article, by the way, is in pre-publication. It hopefully will be released in the next week or two. But we do need a control group going forth, because obviously we don't know how many people in the general population have environmental toxins. We know from the CDC study, but how many have nutritional deficiencies? What's the baseline? So that's a very important question to answer, and we don't have the answers at this point, but it does need to be done.
We only had a clinic that looked at normal healthy people.
I haven't seen a healthy person in a very long period of time.
We have a clinic that looks at normal healthy people. So, all right. So, for Dr. Aucott, are the slice 3 cohort patients seropositive for Borrelia or any other tick-borne pathogens?
So I showed the data on the seropositivity. I think it's like 50, 60% are seropositive. People that had erythema migrans that were treated early generally aren't seropositive at the time of chapter 13, because they started with low titers and they've waned. So it's about 50, 60%. It would depend on what proportion of your patient cohort had erythema migrans versus later manifestations. The later their treatment occurred, the more high their titer would start, and so it would wane slower. So it all depends on what distribution of their presentation was. And we're actually getting ready now to do the co-infection testing. So we have a collaborator set up that we're getting ready to do that. Yeah.
Any follow-on questions to that, or we want to clarify? Okay. So this is a big question, so I'm going to let you guys both attack it. So someone put up a slide, I think it was Dr. Horowitz, on the various theories, the contributions to what causes PLDS, and maybe I got who presented the slide wrong. But I think there were things like antigenic debris, autoimmune, residual damage, co-infection, persistent infection. But what might be the relative contribution of each of these? And I will just sort of add my own perspective that the whole is probably greater than the sum of the parts here. So this is probably not like a linear additive sort of contribution of each of these, but is there any sort of sense of the relative effects of each of these in contributing to PLDS?
So at least in ours, I think that was the whole point of Pasteur's postulate in medical school. At least in my patient population, it's multiple overlapping causes. So we know that Borrelia causes autoimmune manifestations, but so do heavy metals and certain toxins. It's been published in the literature extensively. But unless you have a subgroup where they have Borrelia and don't have the toxins, you can't really know how that's working. So I think all of those are possible. It was Dr. Ying Zhang who actually presented that this morning. I think it's possible to have debris. Yeah. I think it's possible to have active infections. Some will have co-infections. Some have autoimmunity, some don't. And it's a very heterogeneous population. And that's, in fact, I think the problem with designing the studies. And that's why I'm presenting this, because we've been screening with these 16 points for many years. And we were even surprised, actually, the number of co-infections with tularemia that Duncani may have spread across the US. Until we data mined these volumes of charts, we actually were not expecting to find these kind of results.
So we expect to see subgroups. Yeah. So I started with chronic Lyme disease and then a subset of post-treatment Lyme disease syndrome, but then we expect there'll be subgroups. Within post-treatment Lyme disease syndrome, there'll be people where their illness is being driven more by bacterial factors, and other people where their illness is driven more by autoimmune factors. We already know there's a TLR2 genetic predisposition, a SNP that it predisposes to more inflammatory responses, so there's going to be a subset where maybe their genetics is driving it. So I don't know the relative proportions, but it's clear it's not just one subgroup, even it's going to be subgroups.
Right.
Yeah.
Right. Okay. All right. John, what antibiotics are risk factors for PTLDS?
So we haven't proven this yet, but I'll tell you anecdotally, patients that get treated with quinolones initially just do terribly. And I don't know why that is, but it seems to be a theme over and over again that even though some of the data I think Ying showed that quinolones have activity clinically, I'll tell you the people who get put on Cipro initially before they're diagnosed correctly seem to do terribly. And that's just anecdotal. We're going to be analyzing that because there was a high degree of early wrong antibiotics in our SLICE 3 cohort. And it's really striking that if you get off on the wrong foot with the wrong antibodies, especially a quinolone, things don't seem to go well for you, despite getting put on the right therapy, a few weeks or months later.
Wow.
Yeah. So that's something we're going to be analyzing.
All right. Yeah, Kim has a follow-up. Yeah.
Thank you, John. That's really interesting. It's sort of a fascinating thing. Now, so we tested the MIC of Borrelia for essentially by quinolones. You're a doctor. You say quinolones. These are fluoroquinolones, right? Okay.
I am a doctor,
right,
and I mean ciprofloxacin, levofloxacin
sure,
primarily. Yeah.
So we tested all the fluoroquinolones so we could lay our hands on. They have very poor MICs against Borrelia, with the exception of gemifloxacin. And so it looks like you're doing something, that those are doing something else, right? They're not, instead of killing Borrelia, they're sort of messing up the microbiome probably.
Great. All right. I got a question for Dr. Horowitz here. What is the dapzone MIC?
That is an excellent question, and I don't know that that would be up to you lab researchers to take it next time. But remember, we're never using it alone. This protocol is a triple intracellular protocol of doxycycline, rifampin, and dapzone, right? So it's 3 intracellular drugs. So I think some of the success, at least in my patients, is you saw that there were multiple intracellular infections with tularemia, brucella, occasionally Q fever, Coxiella. You need multiple intracellular drugs to go after these, just like with chronic Q fever, which is a persister, right? You can use up to 2 years of having to take a tetracycline or a tetracycline, right, with quinolones. So I think the advantage of dapzone is not, I don't believe dapzone itself. I think it's the combo, but someone's going to have to, when we looked at the biofilm mass, Eva Shoppe did this in culture, we found that when she combined doxy, rifampin, and dapzone, the biofilm mass was reduced by 50% within 72 hours. When she compared the biofilm forms with doxy alone or dapzone alone or rifampin, it was not as effective. So I can't say about MIC, but I can tell you the biofilms, definitely that specific combo seemed to be working quite well. And it was really based on the tuberculosis work, right, that comes previously from what Dr. Zhang was discussing.
And I'd like to add, Richard mentioned the anti-inflammatory effect of dapzone. I mean, I think a lot of drugs have multiple activities. Doxycycline and tetracycline have anti-inflammatory effects. They're used in skin conditions like acne and rosacea where they're not being used as antibiotics. So it's also difficult to sort out, what the different contributions might be to the actual benefit as well. And so I think you mentioned that as well. Yeah.
Yeah. The one thing I can say though, because my wife has had chronic Lyme disease. We've been married for 22 years and she's been sick our entire life. And it's not until she did this dapzone protocol, she is now 11 months in remission with not one symptom. And I was out in Colorado last week and Olivia, I was her 54th doctor. And Olivia now is 3 months symptom-free for the first time. And when I used the MSIDS model for Olivia, they had done liver biopsies at this young girl at 9 years old. They told her she had Wilson's disease from copper overload. She had alpha-1 antitrypsin. Nobody ever bothered to check it. She had chronic variable immune deficiency. No one ever bothered to check the immunoglobulins. Her mold toxins were off the wall, and she kept passing out because she had Pott's dysautonomia. So I found 4 things on the MSIDS map that 53 Colorado doctors had not looked for. And this is why I'm suggesting that, internists or GPs who are looking at these chronically ill patients, there are certain places you just have to look for these chronically ill patients as to how to get them better. And certainly we find that just by screening through the model, we can find things that otherwise might be missed.
Great. All right. Dr. Aucott, are you looking at the gut microbiome of the SLICE cohorts?
Dr. Kim Lewis is our collaborator on the gut microbiome. Yep.
All right. That was the question. So I guess the answer is yes.
Yeah.
All right. All right. I guess in the follow-on for Dr. Aucott, how would you explain the pathophysiology behind the persistent symptoms you saw in your study? Do you believe that PTLDS could be persistent active infection?
So you kind of outlined the range of potential mechanisms. I think, until we have a sensitive way to directly identify the pathogen, it's hard to answer it, but it's certainly, in the top 3 or a combination of the top 3: persistent pathogen, persistent inflammatory response, genetic background, and how they interact are clearly, I think, where the money is, and we're kind of waiting for the, technology to catch up with us to detect the pathogen at this point.
Right.
Absolutely, yeah.
Any follow? Okay. I can be for either of you. So have you observed any correlation between Lyme and mannose-binding lectin deficiency?
And what?
Mannose-binding lectin deficiency.
So when we send patients to the immunologist to get worked up, sometimes for chronic variable immune deficiency, they do mannose-binding lectin, and sometimes it is off. Mainly the way we do it is we will do pneumococcal antibody titers before and after to see if they have an antibody response. And as I showed you, among the 7% of the patients diagnosed with chronic variable immune, they did not have a response. But yes, we do see occasionally that it is affected, but it's usually the immunologists who work that up for us.
All right. Follow-on questions? All right. So, Dr. Aucott, how do researchers access the biorepository samples? Are there any restrictions or issues a researcher should know about your biorepository?
So I tried to outline today kind of the characteristics of the biorepository and what sample types I didn't go into, but we actually have a formal process where people contact us and we try to collect information because we want to make sure we have the right samples for you and that you have the right research questions for our samples. And then we have a team that reviews possible collaboration requests and then kind of usually end up discussing them because, again, we want to make sure it's a right fit for the samples. Yeah.
Right. Another one for Dr. Aucott. How do PLDS symptoms, this is kind of written in a way I can't understand. I think what they mean, do they differ, does the severity differ by sex? And have you looked into that?
I don't think we've looked at severity by sex yet. That's one of our things to look at. So we haven't looked at that yet, but again, we're really interested in sex-based differences, both in the immune response and the types and severity of symptoms. Absolutely. So to be determined. Yep.
Great. So I'm going to throw in one of my own questions for Dr. Horowitz. So you found there's lots of interesting findings, and there's tests that exist, and there's even actionable sort of recommendations that exist. But have you, I guess, how would we go from all these insights you're getting from your data mining to sort of evaluating sort of care pathways and looking at even like cost effectiveness, predictive value, and all these other, like take it from the initial findings into something that could be put into a more standardized, format? Yeah.
So we've been working on a digital model actually for the last couple of years to try and input this data, and it's not done because we've been a little bit busy on the tick-borne working group and other things we've been doing, but I have actually been working for several years now on a digital model to capture the data with some computer specialists. But I think really the next step for me is I'm pretty much getting ready to do a multi-center trial similar to the 4 NIH, the 3 NIH, and the Beren study that was done, the PLEASE study. I feel like with the results we're getting, I think we're ready to actually do a multi-center trial, taking a look at taking the 16-point model, applying it to patients, and having different control groups, those who do dapzone combination, those who don't. And I'll definitely be pulling in members of the people who are here. Rob Smith from our committee from the IDSA, he said he'd be willing to consult on me. But we need to pull in both sides at this point to design a good study to be able to look at it.
Yeah, I guess it sort of reminds me of, just by as luck would have it, on the subway, I was listening to a podcast with Dale Bredesen, who has got, not this, similar in complexity in terms of I don't know, what is it, 10, 15 point, approach. In this case, he's looking at neurodegenerative disease and looking at a multifactorial approach. The challenge, I think, with these is how do you translate them into sort of something that's systematic and scalable. And I'm going to pick on Nathan Price back there from our ISB, so it might be worth talking to Nathan because they're working with Dale Bredesen on how to take his findings and convert those into something that's systematic and scalable. So, all right, I'm going to take one more question off this, and then we got one more. Oh, in both doctors' opinions, what is the difference between PLDS and chronic Lyme? Oh, this could be a long answer. Why the two different names for the same thing? Are they the same thing? Wow, maybe we should have some drinks before we talk about that one. But maybe that we're going to save you guys because we only have 1 minute left. So you have to give us your short answers.
So my short answer is chronic Lyme disease, post-treatment Lyme disease syndrome is a subset of the bigger. Not everyone with chronic Lyme disease is going to meet the research definition of post-treatment Lyme disease syndrome. That's the short answer.
Yeah, and for me, again, the question came up from our working group, exactly what is chronic Lyme? And that's why I was motivated to do this data mining study, is to look at what I've been looking at for the past 3 decades at this point. So we need to compare apples and apples. So it'd be interesting in your group, for example, to take the model, to apply it, and to find out how many of those patients, in fact, have some of the things that I'm defining as chronic Lyme disease.
I think there's already some similarities. I'll reinforce. We look at POTS, and POTS, I think, is a really unrecognized part of the patient's symptoms sometimes, and it's actually pretty easy to screen in an office visit. You do a 10-minute stand test, and you have an answer by the end of your first visit. So there's some low-hanging fruit that we've commonly identified that should be part of a good comprehensive internist evaluation of any patient presenting with this symptom constellation. So there's some low-hanging fruit that just reflects a good doc's taking care of a patient in the right way.
Great. All right, with that, time is up. Thank you guys again for your discussion and talk. All right. All right.